AFib.
Most common dysrhythmia that you're going to run into, again, normal pathways. I'll just represent them real quick here.
Yep. I know the pathways of the heart.
Okay. So AFib is multiple sites of ectopy that are found throughout the atria. Okay. So these things all fire, they keep firing off, and that causes the atria to fibrillate, or basically have a seizure, right? So the atria are not contracting anymore. It's like an electrical storm within the atria. Now, the thing that protects the ventricles from doing that as well is that the AV node gates down the energy from the
I'm here
atria.
for now.
So, in AFib, when you have all these sites of ectopy, the atria can basically contract or have energy movement 300 to 400 beats per second. But that's not conducive to life. People die with that, right? So the AV node slows everything down. And the AV node typically tops out at somewhere between 180 to 200 beats per minute. Only allows that many impulses through, right? So because the only electrical connection in a normal heart is the AV node, it's going to stop all this excessive electricity and only let so much get through. But what happens is what it allows to get through can be variable, right? So when you look at AFib, one thing you notice is you don't have P waves because it's just a bunch of wiggling up here. So you have this wiggling baseline, and then you'll have a QRS, wiggling baseline, QRS, wiggling baseline, QRS, wiggling baseline. And you can't really predict when the next QRS is going to come, right? It's just kind of all over the place. So we call that irregularly irregular. In other words, I can't predict when the next QRS is going to come.
So regular is the intervals,
yes,
and irregular. So there's irregular. The first irregular is the distance between the QRS.
No. So what they mean by that is there is some regular irregularities, right? So for instance, you look at like an AV block, say like a second degree type 2.
Yeah.
So you have P, QRS, T, P, QRS.
Yeah, wouldn't that just be regularly regular? Because it's, well, I only have 2, but when I have 3, I'm sure it's going to be the same pace at the same P, QRS, and T. Okay, I see what you're saying.
So when you have an associated QRS, these intervals are pretty regular, right? You have a normal heartbeat, but then you just drop some, right?
Yeah.
That's an irregularity. But you can kind of predict, like, there should be a QRS here, right? This is predictable. This is not predictable. We don't know where the next QRS should be, right? So it's irregularly irregular. You have no idea what's going on, right? So this is short, this is kind of long, this is more medium, that's short again, long, medium, who knows what's going on. So you don't know when that next QRS is coming. So that's AFib. Now, what's the problem with AFib? AFib, when the atria just wiggle, they're prone to developing clots, because that's what happens when blood doesn't move. So, if you look at the atria in a little bit more detail, let's say, so here's the ventricle. Okay. And then you have the atria kind of lay over like so. And they have these little cul-de-sacs here. This is the left atrial appendage, right? So if this muscle isn't squeezing and pushing any blood that collects in here out, this kind of just sits here and it starts to form clots. And it's real common in the left atrial appendage that we get clots because the atria is wiggling, it's not squeezing.
Okay.
So that's one of the big risks with AFib. This is why patients with AFib have a much greater risk of stroke, because if you form a big clot and then that eventually breaks free, it goes down in the ventricle and gets pushed out. Now, it can get pushed out to the brain, it can get pushed out to the intestines or something like that, and you can end up with an ischemic gut, you can end up with a stroke, all kinds of different things. Yeah, that's kind of throwing a clot, right? Yeah, so how do we treat AFib? A lot of it depends on, is this new onset or is this chronic management of a patient? If you have new onset AFib and they've had symptoms for less than 36 hours, some people recommend 48, whatever, whoever is recommending it, you can try to convert them out of this AFib and get them back into a sinus rhythm. One big risk with AFib initially is that although the atria is contracting at 300 to 400 beats per minute, they can still have a ventricular contraction rate upwards close to 200, right?
Okay.
And that's going to wear people out, especially if they're older. Their blood pressure is going to tank. They're not going to be hemodynamically stable. So we can either try to convert them out or we can just rate control, right? So different strategies then. If we're trying to convert them, if they're very, very symptomatic, we can just synchronize cardiovert, right? Just shock them. So your very symptomatic patients always get electricity, right? So you're going to shock them. Some of the medications that we can use medications that try to slow the impulses as they make their way through the AV node, because remember that all these impulses have to go through there. So drugs that are good for that are calcium channel blockers.
Okay.
So like diltiazem or something like that's a good medication. Another thing that we can do, that's more for rate control. So we're allowing them to stay in AFib, but we're just slowing down the ventricular response so we can get better filling and better cardiac output with each contraction, right? Okay. There are some drugs that can get the patient out of atrial fibrillation. These include things like amiodarone, Ticazin, stuff like that. The problem is that those medications are okay for a short period of time, even a few months, but once you get to long-term use, they have a lot of bad side effects.
Okay.
Ticazin in particular can cause long QT syndromes and all kinds of stuff. So we typically don't like to leave patients on these medications for a long period of time.
Okay.
If we're also trying to rate control, another way of rate controlling is a beta blocker, right? So beta blockers, they slow sympathetic stimulation of the heart. So you have, the three main effects of sympathetic stimulation are dromotropic, chronotropic, and inotropic effects on the heart. So what that means is...
Yeah, I know the tropin part.
Okay, yeah. So inotropic, contractility, chronotropic, heart rate, right? And dromotropic is the ability of electricity to move through the heart. So if the AV node is allowing a lot of electricity through and you got a patient's heart rate's higher up, like say 180s, and that's affecting them, and we give them a beta blocker and we slow that dromotropic effect, so this AV node can no longer move a lot of electricity through it. That slows the ventricular rate, maybe say down to 110 or something like that, and they're doing better, right? So these two here are kind of rate control medications. Long term, you're going to have to use blood thinners for these patients. If they're going to remain in AFib, you can try some different surgical procedures, ablation, a maze procedure, to basically surgically remove these excess sites and keep them from going into AFib and leave them in a sinus rhythm.
Okay.
So anyways, that's AFib.
Nice.
Short-term management, emergency management's either going to be rate control or zap them, right?
Yeah.
And then long-term management, if they're going to stay in AFib.
Don't use these long terms because of the side effects.
Right, and you can use them for a short time, and you can use those kind of as a bridge to get to these other surgical corrections. But otherwise, you're just going to leave them in AFib and keep them on blood thinners and rate control them long-term so that they don't have tachycardias.
All right. Thank you, Dr. Scott.